to AETCM, the emergency medicine channel. Today let us discuss about acute tubular necrosis and other causes for acute kidney injuries. Acute tubular necrosis is one of the most important cause for intrinsic type of renal damage, and it can lead to acute renal failure in most of the patients. Acute kidney injury is defined as acute. Usually it is reversible with loss of renal function, that means decline in the GFR. It is associated with reduction in the urine output. So most of the patients who is having acute renal failure can have urinary the reduced urinary output acutely. It can be due to pre-renal conditions, renal conditions, and post-renal or obstructive conditions. We will see all these things afterwards. Acute kidney injury is defined as increased serum creatinine more than 0.3 milligram per deciliter within 48 hours, or increase in serum creatinine more than 1.5 times of baseline, and urine volume reduced less than 0.5 ml per kg per hour for last 6 hours. So all these things can be due to acute kidney injury, but the last one, that is renal output, that can occur in many conditions where there is pre-renal renal failure. That means pre-renal renal injury. Now we can see the kidney disease improving global outcome classification of kidney failure, that is KDIGO classification. In that we can see the AKI definition, functional criteria: increase in serum creatinine by 50% within 7 days, or increase in serum creatinine by 0.3 milligram per deciliter within last 48 hours, or oliguria. There is no structural damage to the kidneys. When we do ultrasound abdomen, we can see corticomedullary differentiation is preserved, whereas in acute kidney disease, where there is AKI or GFR less than 60 ml per minute per 1.73 meter square for last 3 months, or decline in GFR by more than 35%, or increase in serum creatinine more than 50% for last 3 months. So all these things are there, but associated kidney damage in less than last 3 months. That means ultrasound shows the changes in kidney, corticomedullary differentiation is lost, and patient can also have other features of kidney failure. CKD is chronic kidney disease is diagnosed as GFR less than 60 ml per minute for last 3 months with kidney damage. So these are the diagnostic criteria for acute kidney injury and acute kidney disease or disorder. Now there are a lot of causes for acute renal failure. First we will see the renal causes, problem inside the kidney. Acute glomerular nephritis, it can be infectious, non-infectious. Acute interstitial nephritis, most of the time it is due to allergy or drug induced like that. Acute tubular necrosis, there are various causes: renovascular, vasculitis, SLE, all these things. So we are going to discuss this in detail afterwards. Pre-renal failure is mainly due to hypovolemia, hypoperfusion, renal artery stenosis, embolism, renal vein obstruction like thrombosis of the renal vein. In that, hypovolemia, hypoperfusion is mainly seen in sepsis, septic shock, and other types of failures like cardiac failure, liver failure with hepatorenal syndrome, NSAIDs, diarrhea with fluid loss, blood loss like trauma with fluid loss, burns with fluid loss, diuretic with fluid loss. All these things can produce pre-renal kidney damage. Now post-renal is mainly obstructive lesions, stones, tumors, prostate enlargement like benign prostatic hypertrophy, malignancy. All these things can produce obstruction to the urinary flow, and that in turn produces damage to the kidneys like hydronephrosis, scarring, then renal failure. Acutely it can present acute shutdown of urinary output obstruction, and it can lead to obstructive uropathy. This is a picture which shows three different types of renal failure. Pre-renal means it's mainly due to reduced fluid to the kidneys, reduced fluid flow to the kidneys, reduced blood flow to the kidneys, like dehydration, heart failure, liver failure with hepatorenal syndrome. Renal is mainly intrinsic renovascular disease, glomerular disease, or tubulointestinal disease. Post-renal, it's mainly obstructive type of uropathy. So these are the causes for acute kidney injury. Acute renal failure, intrinsic causes are glomerular diseases, tubular injury, interstitial nephritis, vascular diseases, and that most important is glomerular nephritis and acute tubular injury or acute tubular necrosis. Acute tubular necrosis is one of the most important cause for acute renal failure. It's an intrinsic renal pathology. It occurs due to the ischemia to renal tubules due to various causes, or drugs which produces nephrotoxicity, infections which can produce nephrotoxicity, transfusion reactions and kidney injury, heavy metal poisoning, septicemia, all these things. There are two phases of acute tubular injury. First one is oliguric phase. The patient's urine output reduces, patient develops fluid overload, patient develops pulmonary edema, patient develops breathlessness, hyperkalemia, all these things. Second phase or recovery phase is diuretic phase. During this phase, patient loses large amount of volume from the body as a increased urine output. So that's a good sign in acute tubular injury. If the urine output suddenly increases and it is more than normal, that supranormal urine output is a feature of diuretic phase of acute tubular necrosis. So two important phases: oliguric phase, that's an acute phase, patient have renal failure with fluid overload, pulmonary edema, breathlessness, all these things. Second phase is the recovery phase, that is diuretic phase, more urine output is seen during that period. Now you can see here the picture, acute tubular injury, there will be glomerular filtration is reduced and there will be tubular injury. That tubular injury leads to the obstruction of urinary flow or fluid flow, and there will be back leak of the fluid into the body. So there is reduced urine output during the acute phase. There are a lot of causes for acute tubular injury. It can be diarrhea, vomiting, endotoxic shock in various types of sepsis, myocardial infarction, congestive cardiac failure, hemorrhages, burns, fluid loss from fistula, diuretic pancreatitis, snake bite, myoglobinuria, hemoglobinuria, hemolysis, hepatorenal syndrome, radiological contrast agent induced injury, aminoglycosides, NSAIDs, AC inhibitors, abruptio placenta, preeclampsia, eclampsia. There are various causes for acute tubular injury. So in any acute illness or any drug induced problem, if the patient is developing renal failure, then we have to suspect acute tubular necrosis. Now we will see another important problem for acute kidney injury, that is acute glomerular nephritis. Glomerulonephritis means that is inflammation and destruction of renal glomeruli. The commonest infections are post-streptococcal infection, that is very common in children, then fungal infection, leishmaniasis, hepatitis B, hepatitis C, HIV. Other systemic infections, inflammatory conditions like SLE, that is one of the most important cause for acute AGN, acute glomerular nephritis. SLE is very important, especially in female patients. Goodpasture syndrome, HSP, inoxazoline purpura, antiphospholipid antibody syndrome, ANCA small vessel vasculitis. So these are the conditions which can produce AGN without any infection. Primary renal diseases like IgA nephropathy, focal segmental glomerular nephritis, membranous GN, crescentic GN, there are different types of nephrotic syndromes also can produce AGN. Now the third variety of acute kidney injury is interstitial nephritis, acute tubulointerstitial nephritis. Now, kidney inflammation is that tubules also damaged. Inflammation of spaces between renal tubules are seen in kidney biopsy. Acute inflammation within the tubulointerstitial cells, most important cause of this is allergy, mainly drug. So it is a drug-induced allergic reaction. What we see routinely, we see is drug rashes over the skin. Here the kidney is also involved. It can also be caused by autoimmune diseases like SLE, Sjogren's syndrome, sarcoidosis, Legionella, leptospirosis, streptococcal organism. Leptospira is one of the very important cause, commonest cause for interstitial nephritis, because leptospira is very common in our country. Leptospira presents with 2-3 days of mild fever, severe back pain, muscle pain, conjunctival suffusion, all these things, and fever subsides in after 2-3 days. There will not be any fever for some 1 or 2 days. Then patient slowly develops renal failure, jaundice, altered behavior, thrombocytopenia. That is the second phase of the disease. First phase is leptospiremic phase. The patient will have only symptoms like a viral fever. Second phase is an antibody mediated multi-organ dysfunction phase, that is called as Wheel syndrome. So during that phase, patient can have various types of nephritis. One of the type is interstitial nephritis. Many drugs can produce interstitial nephritis: sulfonamides, beta-lactam antibiotics, vancomycin, erythromycin, rifampicin, ethambutol, NSAIDs, allopurinol. In that, allopurinol is very important, one of the major cause for acute interstitial nephritis. Anticonvulsants like phenytoin, phenobarbital, carbamazepine, valproic acid. Infections like bacterial pyelonephritis, streptococci, Legionella, tuberculosis, leptospirosis, salmonella, brucellosis. Mushroom poisoning is another important. In mushroom poisoning, patient mainly present with LFT alteration, acute hepatitis, but many patients can have interstitial nephritis also. Now, differential diagnosis for acute renal failure. If you see the chart, you can easily make out what is the problem in the kidneys. Extrarenal cause we will not go now. We can see acute tubular necrosis, acute glomerular nephritis, acute interstitial nephritis. Here, urine creatinine ratio is very important. In a pre-renal failure, pre-renal cause for renal failure, urea will be high than proportionately high than creatinine elevation. So very high levels of urea and creatinine is not that much elevated, then it is mostly in favor of a pre-renal cause. Like urea is 200, creatinine is only 2. That is a disproportionate elevation. That means it's a pre-renal cause. Whereas urea is 40 or 60, creatinine is 3. That is a proportionate elevation. So that is mostly a problem inside the kidneys. So this chart will tell you how to differentiate between various type of renal injuries, but in that most important is the history. History is very important. Like patient who is having drug induced problem, then it will be mostly acute interstitial nephritis. Like that, various problems are there. Skin infection is there, then mostly it is a child with skin infection, renal failure, mostly it is a acute glomerular nephritis. Like that, we can make out a patient who is having SLE coming with glomerular nephritis, then it is a SLE induced problem. But whatever it is, disproportionate elevation of urea will tell you that the problem is extra-renal. It's a pre-renal condition. Again, other things also you can make out. When you do ultrasound, if it is a renal problem, that changes may be visible, and if it is a chronic kidney disease, corticomedullary differentiation can be absent. Anemia is classically seen in chronic kidney disease. A patient coming with acute on chronic kidney disease, acute renal failure on a chronic renal problem, then also you can see the patient may have some anemia. Now there is a classification of ARF, that is rifle classification: risk, injury, failure, loss and end stage renal disease classification. So here, according to this, you can have creatinine and urine output. So risky serum creatinine increased by 1.5 times of baseline, 0.5 ml per kg per hour, 6 hours. Injury 2 times for 12 hours, 0.5 ml per kg, urine output reduced. Failure, again, it increases, the problem increases, creatinine become more, and urine output has become 0.3 ml per kg per hour for last 24 hours, or anuria for 12 hours. Loss, creatinine has become more than 4 for a week. End stage, for a month there is no need of renal replacement therapy. That is rifle classification of acute renal failure. Now, other investigation also we have to do in renal failure. We have to find out the causes. We have to see whether it is infection. So you do a complete blood count and CRP and procalcitonin. To rule out infection, we have to do procalcitonin. To see what is the amount of inflammation, you have to do CRP. To see whether there is a bacterial infection, we can even see blood counts. Then urine for RBC or WBC cast. Urea will be highly elevated in pre-renal failure. Dehydration also, urea will be highly elevated. Even sodium also can be, serum sodium can also be very high in pre-renal cause for renal failure with severe dehydration. Creatinine can be elevated in most of the renal failures, but creatinine rarely can be elevated in rhabdomyolysis also, like trauma patients that can have creatinine elevation without kidney damage. Creatinine indicates kidney disease, but rarely it can be elevated due to rhabdomyolysis without kidney damage. Otherwise, creatinine is a better marker than urea. Other investigations, you can get sodium. Some patients, sodium can be lost through the kidneys, like salt losing nephropathy. You can lose sodium through the kidneys. But otherwise, in a patient who is having renal failure with volume overload, there will be falsely reduced sodium, that is dilutional hyponatremia can be there. Calcium hypocalcemia can be indicator for chronic renal disease than acute renal failure. Serum phosphate levels also can be elevated in patients who is having low GFR. Potassium is very, very important, because both in acute renal failure and chronic renal failure, potassium can be elevated. But the problems due to hyperkalemia in acute renal failure is more dangerous than chronic renal failure. The same levels of potassium in acute renal failure is more dangerous than a same level of hyperkalemia in a chronic renal failure, because chronic renal failure, the high potassium, patient's body may be adapted to that high levels of potassium for many days. But here it is acute elevation, patient can have problems like ECG changes can be there. There will be tall T waves, there will be PR interval prolongation, there will be QRS prolongation, there will be QT prolongation, finally sine wave pattern, bradycardia. So many complications can occur due to hyperkalemia. Chest X-ray mostly shows bilateral non-homogeneous opacities. So that can be due to either fluid overload, like a renal failure induced fluid overload, or due to ARDS part of the infectious process, or due to high urea induced lung injury. That is a type of ARDS, it's called as uremic lung. So various causes are there for a white non-homogeneous shadow bilaterally in the chest X-ray, but the commonest cause is fluid overload with pulmonary edema. Now ECG, you can see very tall T waves all over the ECG leads. Almost all leads have very tall T waves. That's a sign of hyperkalemia. Whereas in acute MI, it will be confined to some leads. Suppose it's a anterior wall myocardial infarction, it will be tall T waves in V1, V2, V3, V4. But whereas in this condition, hyperkalemia, there is a universal elevated or tall T waves. Now chest X-ray, again we have told that bilateral fluffy shadows or non-homogeneous or homogeneous shadows throughout the lung fields, or sometimes it is called as bat wing appearance. Both sides you can see the shadows. Here what is happening is alveoli is full of water. Okay, some alveoli are collapsed, some alveoli are full of water or our body fluids, so that reduces the oxygen interaction, oxygen dilution or diffusion. Now, how to manage acute renal failure? We have two important problems in acute renal failure. It is not like a chronic renal failure. In acute renal failure, we have in emergency room we have two important problems. One is hyperkalemia, other one is volume overload. These are the only two important conditions we have to tackle from the ER in acute renal failure. Anyway, in emergency room we have to take care of the airway, breathing, circulation. Airway can be compromised. Airway breathing can be compromised because of pulmonary edema. Circulation can be compromised because of hypotension in sepsis or hypertension in a case of glomerular nephritis or acute glomerular injury. So all the three categories are possible. Pulmonary edema with pulmonary edema with normal BP, pulmonary edema with hypotension, pulmonary edema with hypertension. All are possible in acute renal failure. In that, when we have hyperkalemia, if the patient is having acute renal failure, normally we should understand that potassium is cleared through the kidneys. If the kidneys are damaged, potassium will not be cleared through the kidneys and it will accumulate in our body. So hyperkalemia can produce, most important problem of hyperkalemia is cardiac problem, that is arrhythmias. It can produce arrhythmia. So we have to give membrane stabilizer first. Whenever there is hyperkalemia, and if the patient is having ECG changes, we have to treat it with membrane stabilizers. But we can see many patients who is having normal kidneys, sometimes we can get elevated potassium. That is mostly because of an error in the lab investigation. So a patient who is having high potassium without renal disease, mostly it is an error. But if the patient is having high potassium with kidney injury, then it is dangerous. If there is elevated potassium with ECG changes, then it is more dangerous. So if there is ECG changes, we have to give calcium gluconate. Calcium gluconate is a drug which can stabilize the membrane, which can prevent the arrhythmias. 10%, 10 ml over 10 minutes can be given to prevent arrhythmias. It acts for 30 to 60 minutes. Insulin dextrose infusion can shift the potassium into the cells from the intravascular compartment. So you can give 10 units insulin with 5% dextrose at 100 ml per hour. That can be given. If the patient is having high blood sugar, give only insulin. If the patient is having low blood sugar, give only dextrose. So all the three things will decrease the potassium, whether it is only insulin or only dextrose or insulin dextrose infusion. All can shift the potassium. So that can be tried if the potassium is high with suspected ECG changes, and the action starts very fast, 15 to 30 minutes, and it lasts only for 4 to 6 hours. The third option is diuretic, but remember, in a patient who is having renal failure, this is not going to work, because the action of diuretic or furosemide is it removes potassium from the body through the urine. So if there is renal failure, we cannot use it. The fourth one is potassium binders. We cannot use these drugs in emergency room, because this only prevents the absorption of potassium from the intestine. So that takes time. So there is no role for this type of drugs in emergency room. But however, it can reduce the potassium absorption from the intestine. It is very useful in a patient who is having hyperkalemia, persistent hyperkalemia, who is admitted to ward. And if the patient does not improve with all your treatment, hyperkalemia should be managed with dialysis, because all the parameters, all the drugs what we discussed, they only transiently reduce the potassium from our body. Only Lasix can remove potassium from our body, but we are not able to do it because the patient is having renal failure and complete renal shutdown. So this patient may require dialysis to remove the potassium from the body. Second problem is water. So first problem is hyperkalemia, because that is more dangerous problem. Second problem is volume overload, pulmonary edema, breathlessness. So this can be treated with only NIV. So BiPAP ventilation is the treatment of choice. BiPAP or CPAP or NIV, that is a treatment. So that acts like it gives a positive pressure ventilation. Positive pressure ventilation is given so that the collapsed alveoli or fluid filled alveoli, there will be some pressure build up and the fluid in the alveoli will be displaced out so that oxygenation will be better, and collapsed alveoli will be opened, dead spaces will be opened. So there will be space for breathing and space for good perfusion and good oxygen transportation. We have to advise the patient not to take extra water. Water has to be restricted, water intake has to be restricted, strict intake output chart has to be maintained. Salt intake should be reduced because if the patient takes more salt, more fluid retention will happen. So that should be avoided. Diet, again protein restriction should be done. Protein overload can increase urea. Again, uremia can occur. A lot of complications can be produced by high urea. That patient can have encephalopathy, pericarditis, breathing difficulty, that is uremic lung. So many toxic problems can occur due to uremia itself. Now we can see the indications for dialysis, like patient is having persistent symptoms of uremia, intravascular fluid overload, not responding to Lasix, hyperkalemia with severe acidosis, not responding to medical treatment, uremic pericarditis, uremic encephalopathy. All these things we need to do urgent dialysis, and prophylactic dialysis can also be done in very high urea with very high serum creatinine. So these are the things we have to do in acute renal failure. So we have discussed about one important problem in emergency room, that is acute renal failure. It can be due to acute pre-renal failure, like sepsis is one of the most common cause nowadays. Then intrinsic renal failures like acute tubular injury, acute interstitial nephritis, and obstructive uropathy, that is another important cause. Stones, strictures, malignancy, but don't remember about BPH. BPH is one of the most common cause for obstructive uropathy in our country. BPH can produce acute obstruction of urine and increase post-voidal residual urine. In diabetic patient, it produces a lot of complications like cystitis, urinary tract infection, all these things. So we have to also think about obstructive uropathy also. Thank you.